are continuing our Urology FRCS Part 2 Viva training. We are continuing with our technology table. As you can see, so much of topics to discuss in technology. Today we'll discuss the technologies in relation to stones. Anish, floor is yours.
Thank you so much, and good morning, everyone. So we will use this opportunity to discuss all the things based on the stone technology. What I'm not discussing today is laser because I think we have already discussed that based on the BPH scenario. So rest of the all the technology will be discussed today. Shall I start now? So uh, you you are sitting in the um, stone outpatients. There is a patient, young lady. She has got a 8 millimeter stone in the right renal pelvis. She is symptomatic. She has no other comorbidities, no family history of stone disease. What are the options that you're going to discuss with her?
Um, the options that I'll discuss with this woman in terms of managing her stone would include conservative management and surveillance, but given that she's symptomatic, I will discuss extracorporeal shockwave lithotripsy and ureterine rhinoscopy and laser lithotripsy.
Okay. What are the types of shockwave generators you are aware of?
So I'm aware of the electrohydraulic lithotripter, piezoelectric, and the electromagnetic.
What type of uh, lithotripter is used in your department?
It's the electromagnetic that is used in my own department.
Okay. How does a electrohydraulic generator work?
This consists of a electrode which is contained within a water bath, and that's surrounded by an acoustic reflector. And when an electrical current is applied to the electrode, it generates an underwater spark plug. This then produces heat, vaporizing the water, and produces gas bubbles. And these then expand and collapse to produce a shock wave. And the shock wave is then reflected by the surrounding acoustic reflector to be focused onto the stone.
Okay, so the electrode will be at, so it's like an ellipsoid, isn't it? The electrode will be at F1 and the shock wave will be focused at F2 where we started the stone. And what's the difference in electromagnetic generator? How does it produce shock wave?
With the electromagnetic, the shock wave is, electrical currents generated by the generator, and that then passes through a thin metal membrane, which then provides the shock wave, and the shock wave then passes through an acoustic lens, which I can't remember if it's convex or concave, but that lens helps reflect and focus the shockwave onto the stone.
Okay, so what's the because we are mostly using electromagnetic now rather than electrohydraulic, what's the reason for that? Why electromagnetic is more popular?
The electromagnetic is smaller, so it can be incorporated into the table at the same time. It's able to generate a bigger shockwave, which is more reproducible. The power can be increased, and the element of the electromagnetic is more durable, and there's also more accurate focusing of the shockwave.
Okay, well done. Are there any disadvantages of electromagnetic compared to hydraulic one?
The electromagnetic is possibly more expensive, and expensive in terms of maintenance.
Okay. Yeah, and one more thing is because you said that it has got high energy density at the F2 focus, so it can result in more subcapsular hematoma compared to the electrohydraulic, but still the overall subcapsular hematoma formation is around only 4%.
Yeah.
And what about piezoelectric? How does it differ from the other two?
So this consists of a semi-spherical arrangement of piezoelectric ceramic discs. When a current is applied to these discs, they expand and contract, and this then produces the high-frequency ultrasound waves. And because of the ellipsoid arrangement, this then is the way in which the shockwave is focused onto the target.
All right. And what's the disadvantage of this one? Why it is not popular?
It's the arrangement of the crystals is not entirely perfect, so the shockwave could be dispersed over a wider area than intended.
Exactly. So the actual energy delivered is much less compared to the other two. And in the extracorporeal shockwave lithotripsy, what are the imaging systems that we usually use?
They're usually plain film, abdominal X-ray, or ultrasound.
Okay. And in the machine, what are the imaging systems that we usually use?
In the machine itself, it's X-ray.
Okay. So there is fluoroscopy, and there are machines where they use only ultrasound alone, but most of the time it is a combination of both ultrasound and fluoroscopy. And it is common to ask in the exam to draw the pressure pulse at the F2 focus.
Yeah.
Can you explain to me how it looks like? What's the positive wave maximum? What's the negative wave? And what's the duration of the pressure pulse?
So essentially, there's an initial peak of there's an initial sharp peak of positive pressure, with the pulse going up to a maximum of 40 megapascals from a baseline of 0. This then followed by a prolonged wave of negative pressure going to minus 10 megapascals. And the sharp peak is over, I think, 0.3 microseconds, and the negative peak is over 2 microseconds. Negative wave, sorry.
Okay. So what are the principles by which stone is fragmented during shockwave lithotripsy?
There are two main processes that occur. The first is spallation. This occurs when first the acoustic impedance happens, and this is when the transmission of the shockwave is impeded by it meeting the stone, which is of a high density. So the shockwave is reflected off the surface. This creates a compressive stretch and stress which overcomes the tensile strength on the surface of the stone, leading to microfractures, and then the shockwave is reflected off the trailing edge of the surface and hits other parts of the surface. Therefore, this leads to more microfractures. And the second process is cavitation, where plasma bubbles coalesce at the stone surface. And when a shockwave passes through them, the bubbles will then expand and collapse and release microjets of energy which are directed against the stone surface.
All right. How can we improve the outcome of shockwave lithotripsy?
So this can be improved in a number of methods. You need to ensure that the patient is adequately analgesed prior to the procedure, commonly with diclofenac suppository. The frequency of shockwaves should be commenced at 1 per second. And during the procedure, this can then be ramped up with the energy ramped up as well. The energy can be ramped up in the power. And post-procedure, patients can be prescribed tamsulosin to help with clearance of the stone fragments and reduce the likelihood of hospitalization. And you also have to ensure correct patient selection at the start as well.
All right, well done. Because you said that the second option that you will discuss with the patient will be ureteroscopy and laser. What are the types of ureteroscope available?
They are a rigid ureteroscope and a flexible ureteroscope.
All right. I will slightly change that answer in the sense that it was a rigid ureteroscope before, when it was originally invented in 1979, because initial rigid ureteroscopes were using rod lens, but currently we call it semi-rigid because it is up to a level it is flexible. I mean, we can bend. It's not flexible. Sorry, it can be bent. The reason for that is, even in semi-rigid ureteroscopes we use fiber optic, which is encased in a metallic case. So rigid ureteroscope was the previous designs, and since 1989 it is changed into semi-rigid ureteroscope, and we use the semi-rigid ureteroscopes now. What are the parts of semi-rigid ureteroscope?
So this consists of the eyepiece, the light post, the irrigation channels, the fiber optic system, and the working channel. The working channel itself, if it's a single one, it's 3.4 French. And if there are two of these, then they're usually 2.3 French. And the tip can vary from, in my experience, anything from between 4.5 French to 8 French.
Well done. And how does a flexible ureteroscope differ from a semi-rigid ureteroscope?
A flexible ureteroscope is longer, so it's typically 70 to 80 centimeters long compared to 34 for the semi-rigid ureteroscope. Flexible scope has only one working channel. It too uses fiber optic for light and image transmission, but the bundle, the fiber optic cables, fibers are bound in a plastic sheath and coating compared to metal for the rigid ureteroscope. The flexible ureteroscope also has a tip which can deflect the distal tip.
Okay. And what are the type of fiber optic bundles used in a ureteroscope?
The main type are coherent, so they have the same arrangement at both proximal and distal ends to reproduce the image quality that's received at the tip.
And how does a digital ureteroscope differs from a conventional flexible ureteroscope?
So with a digital scope, the image, or the fiber optic bundles in a flexible in conventional one are coherent, but in a digital scope they, I think, are non-coherent, and the image is produced from a photon or packet of light striking a charge coupled device, which is a microchip on the tip of the digital scope.
Okay, well done. So it is the chip on the tip technology, isn't it, in digital scope? And the image is carried by the electric fibers, and the light, again, it is the non-coherent fiber optics that we use. And CCDs, the charge coupled devices, are used in some of the flexible ureteroscopes, and there are flexible ureteroscopes that use the CMOS technology as well. So both are used in for the digital ureteroscopes. Coming to the advantages, what are the advantages of digital ureteroscope compared to the conventional fiber optic ureteroscope?
So a digital scope is disposable and does not require sterilizing. In my experience, it doesn't require attachment to a separate camera head. Therefore, there is less kind of rotation and twisting during the procedure. and they have been found to be blighter as well. And the main advantage is the image quality that's reproduced. It has got a better definition than the conventional scope. This disadvantage are concerns about the impact on the environment. The tip is wider and thicker than the conventional scope, and they currently are more expensive than the conventional scope.
Exactly. And there are also situations where we cannot put the digital scope straight, isn't it? Sometimes the ureteric orifice will not accommodate a digital ureteroscope, because most of the digital scopes are a bit, the circumference is a bit larger compared to the conventional scopes. So sometimes if we use only the digital scope in our department, then sometimes we might have to stage the procedure.
Yeah.
Coming to the procedure itself, when you use guide wires, what are the different types of guide wires you are aware of?
Guide wires can be classified in a number of ways. Broadly speaking, I classify them according to whether or not they have hydrophilic elements or not. Those which do not have any hydrophilic coating include the standard polytetrafluoroethylene guide wire and the Amplat superstiff wire, and those with hydrophilic elements include the sensor guide wire with the hydrophilic tip and a Terumo zip wire which has hydrophilic coating throughout its entire length.
Okay, well done. And what is the core of the standard guide wire? As you said that it is covered by PTFE, so what's the core?
It usually has it's got a inner stainless steel core.
Well done. And how does it differ from the glide wire or Terumo wire?
So the PTFE wire does not have any hydrophilic coating on at all. And it is coated only with polytetrafluoroethylene. It doesn't have a polyurethane coating. Compared to the tip is flexible as well, compared to the hydrophilic, compared to the Terumo wire, which doesn't have a specific flexible tip.
Okay. What is the core of glide wire or Terumo wire made of?
This consists of a nitinol core.
Well done. Okay. What is the most common type of guide wire that you use in your daily practice?
I use the sensor guide wire the most.
Okay. And what's the difference between a sensor guide wire and the other guide wires?
So a sensor guide wire's core is composed of both nitinol and stainless steel. Throughout most of its length, it is coated with PTFE, but the tip is hydrophilic and flexible, and is coated with a hydrophilic polymer coating. And it also contains tungsten, which allows for fluoroscopic visualization. So it combines the properties of both being hydrophilic, but also ensuring kind of good memory and hold within the ureter, not slipping out.
Well done. What is a bi-wire?
I'm sorry, I've not come across this before.
It's only difference is that everything else is same, but it has got double floppy tip, so it is flexible at both ends. So if you are very concerned regarding the damage of flexible scopes with the tip of the guide wires, then you can use a bi-wire. Not popular, but still might be asked, especially because we are moving more towards only flexible ureteroscopies era. Do you normally use a ureteral access sheath during the flexible ureteroscopy?
So the choice as to whether an access sheath is used depends on different factors. If the patient has been pre-stented prior and the ureter is known to be dilated or had previous stone surgery on the ipsilateral side, then it is more likely to accommodate ureteric access sheath. However, where there is a ureter which has not been operated on before, then it could be argued that using a sheath in this scenario has a greater risk of ureteric trauma and avulsion. And in my practice, I prefer not to use ureteric access sheath in this particular scenario.
Okay, that's a well-formed answer. So, what are the advantages of using a ureteral access sheath?
This permits the repeated insertion of instruments in and out of the renal pelvis without causing persistent ureteric trauma from the instruments, and therefore theoretically reduces the risk of ureteric stricture. It can allow for stone fragments of adequate size to be retrieved through the sheath, again without injuring the mucosa, and it also reduces the intrarenal pressure during ureteroscopy.
Okay, and there are papers which says that it can reduce the operative time as well. And what type of access sheath that you use in your daily practice?
So I commonly use a 45 centimeter sheath with the diameter ranging from 11 to 13 French. But depending, I also use a 35 centimeter sheath if the ureter is shorter, or if I have a female patient, where the urethra is shorter too.
Coming to the ureteric stents, which type of ureteric stent that you use in your practice?
So I commonly use a polyurethane stent, which lasts for up to 6 months. However, I also use silicone stents, and they're available in my practice, and these can last for up to 12 months.
Okay. And what's the disadvantage of having a silicone stent? Because the polyurethane
disadvantage.
The disadvantage of silicone stent over polyurethane or a Percuflex stent. So polyurethane is the standard.
They're more expensive, but
yeah. The reason is the polyurethane is the standard one, but it's a bit more stiffer, so it can cause lots of irritation in the bladder and stent symptoms. Silicone is good because it is inert, but the problem is that it is very soft, so the inner core can collapse, and that's why there are new copolymers. One thing that is most commonly used in NHS is sorry to say the trade name, but still it is Percuflex. So it combines the qualities of both polyurethane and the silicone. With the copolymers, we can achieve a good balance between the inner diameter and outer diameter. So they have got a bigger lumen, inner lumen. So they drain the kidneys well, and also because they are biocompatible, it can be left for a long time. And at the same time, they are softer, so it causes less bladder irritation. So standard one was polyurethane. Then we went to silicone to decrease to use an inert material, but it was too soft. Then we found something in between by using the copolymers. What about metallic stents? It's not related to stones, but still, if you discuss on stents.
Yep. So an example of a metallic stent is the Miniperc, which is made out of nitinol, composed of nitinol, and this is used. This can be used in the management of either benign or malignant ureteric strictures, where a patient, for example, may not be able to tolerate the symptoms and side effects of the other conventional stents, and where they, for example, desire less frequent stent changes. So Miniperc stent is shorter. It bridges the length of the stricture, and it can be changed every kind of 5 to 10 years, but it's not frequently inserted, and it risks kind of incrustation, migration, and difficult changes.
Okay, well done. So regarding the answer, because there's a good chance that you will get a STEM question in the exam, especially in the technology table. I put a PowerPoint slide based on this in the discussion. So when I would suggest that answer can be modified as whenever you are asked about stents, if there is a question like what are the types of stents you are aware of, then you can say that there are stents based on polymers, there are metallic stents, and there are biodegradable stents which are not commonly used. And in the polymers, the most commonly used ones are polyurethane, silicone, and the copolymer stents.
Yeah.
So if you give it like in a systematic order, then you can score high marks, isn't it?
Yeah.
Coming to the stone baskets, what type of stone basket do you use in your practice?
The types of stone baskets I commonly use are tipless ones. So examples would be the encircle and engage. And there is also other types of baskets, such as the Gemini. Those are the ones I commonly use in my practice.
All right. Regarding because engage is one of the most common basket used in our practice, what's the diameter or the open diameter of engage tipless basket?
So when the basket's fully open.
When the basket is fully open, yeah.
So the full diameter of this is approximately 9 to 10 French.
Okay, yeah. So there are two numbers that we usually ask for. So it could be either 8 millimeter, especially in the lower pole stones once we fragment, or if you want to reposition it to upper pole. So mainly there are two sizes that we use. So one, when it opens, it is 8 millimeter, and the other one is 11 millimeter. Okay. So that's why we have to fragment the stone to at least up to 8 millimeter, so that we can either reposition to a better position to fragment it.
Yeah.
And there are other, as you said, Gemini is the helical one. So there are tipless one, and there are open tip, and helical ones. Helicals are mainly used in the ureter. Gemini is the most commonly used in our practice. And there is a previous one which is not popular nowadays because it had a hemispherical shape. It was called as a Segura basket.
Yeah.
So again, in your stone clinic, we are moving on to a different scenario. In the stone clinic, there is a patient with a 3 centimeter complete Staghorn calculus. Otherwise, the patient is fit and well. So what procedure are you going to offer to him?
Given the size of this stone, it's more than 2 centimeters, I will discuss percutaneous nephrolithotomy with him as per recommendations in the NICE and EAU guidelines.
Okay. And which position you use in your PCNL practice?
So I am familiar with the modified Gaudacchio Valdivia position. So the patient is supine. The flank is elevated with a 3-litre irrigation fluid bag. The ipsilateral leg is straightened, but the contralateral leg is in a kind of semi-lithotomy position. So this allows access both to the percutaneous access area, but also permits retrograde access.
Well done. Coming to the instruments used in PCNL, what type of access needle you use for the initial puncture?
So I'm not familiar with this.
Okay, so if that the couple of things that you need to aware are, one, the access needle, and the second one is the sheaths, type of sheath we use, and also different types of PCNL. I know it is not commonly used nowadays, the PCNL, except for complete Staghorn or even for a partial Staghorn calculus, which is rare nowadays. Mostly we are using ureteroscopes, isn't it? But for the teaching purpose, especially if there is a question on PCNL, we will be expected to answer questions on that. So the access needle, there are mainly three types. One is called as an initial puncture needle. So there are 3-part initial puncture needle, 2-part needle, and Shiba needle. The most commonly used ones are the 2-part needle, where there is an inner stylet and there is an outer sheath. The only difference in 3-part is it has got a extra outer sheath which is very thin. So the puncture onto the kidneys are, if you want to do multiple punctures, if you're not getting access with the first puncture, it is claimed to have better or less bleeding compared to the 2-part needle. So 2-part needle is the most commonly used one. The parts of the needle are shaft and stylet, and then the tip can be beveled or diamond tipped, or it can be short or long needle. I have put the slides in the discussion. And are you aware of the tract dilators, different type of tract dilators that are used?
Somewhere there are metallic Olkins dilators, which are serially graded in terms of size. So one dilator is inserted over the guide wire.
Okay. Can you hear me? Sorry, I think I lost you there.
And I'm also aware. Can you hear me now?
Sorry, I think there's a connection problem.
You can repeat the answer, Piyush. I think we lost you for a minute.
Okay, thanks.
Piyush?
Yeah. Yeah, I think we lost the connection.
Yeah. Okay, we'll wait for him to come back.
Yeah. Shall I ask you one question? Yeah. Mr. Dhanasekaran.
Yeah.
Because most of the time I have heard, even in the Viva mock exams, people say, the answers given as rigid ureteroscopes. Is it better to say that semi-rigid, isn't it? Because the
the rigid ureteroscope is a wrong terminology. We need to say semi-rigid ureteroscopes and flexible ureteroscopes. And the semi-rigid is semi-rigid because inside it's all flexible fibers, just like our flexible ureteroscope. Only the sheath, the outer stainless steel sheath, is semi-rigid. And as you said, it's quite bendable, and that increases the shelf life and increases the image quality also. Yes.
Exactly.
Hello, can you hear me now?
Yeah.
Yes, please go ahead. Yeah.
Thank you.
Sorry, I don't know what's happened with it. So going back to the question about the dilators.
Yeah.
So there are metallic dilators, which involve serial dilatation going up in sequence, but involves a large dilator being large sheath being put over a smaller sheath, and serial insertion and removal. And there is also dilatation of the tract using a balloon up to a certain pressure. And then over that is then inserted a plastic sheath. I think the metal dilators are called Olkins dilators.
Exactly. So yeah, as you said, there are plastic dilators, metal dilators, and the balloon dilators, which are the most commonly used now. And the plastic dilators can be just facial dilators, serial facial dilators, screw dilators, and the most popular one is the amp-plus dilators. The other one is the telescopic metal dilators, also called as Alkan dilators. Most of these are fallen out of favor because of the popularity of the balloon dilators. The only disadvantage of the plastic dilators, or the most common, the amp-plus dilators, was with each, it was more like we had to insert it and then take it out to insert the next dilator. So there was a chance of bleeding with each removal of the previous dilator. That was overcome with the alkane dilators, where it is like serially we are putting one above the other, and a metallic knob will prevent the telescope dilators from passing beyond a certain point. And the most commonly used one nowadays are the balloon dilators. Do you know the advantage of balloon dilators compared to the other dilators?
So these result in kind of less incidence of trauma to the kidney. The dilation can be controlled in terms of doing it to maximum pressure, not going beyond that. And I suppose there may be also a bit of a tamponading effect within the tract from the effect of the balloon to reduce the risk of bleeding.
Exactly. Well done. So after the initial puncture, using the dilators, we will dilate the tract, and then either you can use different methods. Finally, there should be two wires. So we call one as the working guide wire, and the other one as a safety guide wire. And over the working guide wire, we put this balloon dilator. The advantage of balloon dilators is that the balloon dilator is a radial dilator, and because the other ones are axial, so we have to put it one by one through the sheath. But this is once the balloon dilator is within the kidney, which we can know by the radio opaque marker at the tip of the balloon dilator. Once it starts dilating, it is a radial dilatation, so the compressive force are more lateral rather than pushing the kidneys all the way. Once it is in the main caveat that we have to make sure is that the AM plus sheath should be backloaded before starting the dilatation of the balloon dilator. The balloon pressure, as you said, it varies. It can vary from 15 to 30, but usually the average one that we use is around 18 atmos during the dilatation.
Atmospheres, yeah.
And how we know that it is time for us to thread the AM plus sheath over the balloon dilator is by visualization under fluoroscopy. So what we inject is the contrast, and then the term there is, the keyword there is the shouldering of the balloon dilator. So we can visualize the shouldering during the fluoroscopy. So once we are sure that the balloon dilator is dilated to the maximum possible and the average one is 18 atmosphere, then we can thread the AM plus sheath over the balloon dilator and keep in position.
Yeah.
Well done. And what type of nephroscope do you use in your practice?
So in my practice, I use a size 24 nephroscope.
And so there are two types, isn't it? There are rigid nephroscopes and flexible nephroscopes were also available. Nowadays we use the flexible cystoscope as nephroscope. And again, the parts could be eyepiece and sheath and telescope. And yes, most commonly used ones are 24 and 26 French. Do you use Miniperc in your practice?
So I've not used it in my practice personally, but I am aware that it is increasing popularity nowadays due to the smaller tract size used, and the kind of theoretically perceived lesser risk of complications with the smaller tract size, such as bleeding and such as bleeding and injury to adjacent structures.
Okay. Yeah, exactly. So it is gaining in popularity. There is no clear definition between the tract size between a standard PCNL or a Miniperc, but it is accepted that anything less than 20 French can be called as Miniperc. But having said that, there is a dilator size of our Miniperc size of 21-24 available. The most commonly used one are the 16.5 and 19.5, and there is a lesser one available, 15-18 size. So these are the so if it is 16.5, 19.5 means 16.5 is the inner circumference and 19.5 is the outer circumference. The advantage is has that is that it has got its own dilators, and we had to use the special telescope. It is a 22 centimeter with a 6.7 French working channel. It's difficult to use the lithotripsy instruments through that one, so we had to use a laser for the lithotripsy.
Yeah.
And the it's a very clever system where at the tip it will create a whirlpool effect. So it is designed for that fluid to come in with high pressure, and then it expands like in a fountain. And then so what happens is, when you withdraw your, after the lithotripsy, when you withdraw your scope, the stones easily wash out through the scope.
Yeah.
What about Microperc? It is not popular, but still it is hailed as a very it's an invention, or it is a advance in the field of the stone disease. Do you know about Microperc?
I think what I know about is that the tract size is even smaller. It can range from 11 to 13 French. Again, given its size, only flexible instruments can be used down it along with a laser. But beyond that, I'm not sure what further I can talk about it.
Yeah, no problem. So for the stones, it's very unlikely that it will go beyond a Microperc, but still, if we are aware of the options available, so one is a standard PCNL, which mostly the track size that we use is with the Amplast is 26 to 30 French. The other one, the Microperc, we discussed, it is less than 20 French. Sorry, the Miniperc, we said that it is less than 20 French. Microperc is much more smaller. So it has got something called as a all-seeing needle. So it is only really a needle there only, and the size is 4.85 French. So that is the lowest in the available stone fragment instruments. So Microperc is 4.85. The one that is 11 to 13 French is called Ultra Mini PCNL.
Yeah.
So it is standard PCNL around 26 to 30.
Mm-hmm.
Mini PCNL less than 20. Ultra Mini PCNL, and it is 11 to 13. And the Microperc is 4.85 French.
Yeah.
Okay, and again, you are in the stone clinic. There is a gentleman with a 2 centimeter bladder stone and enlarged prostate size of 50 cc. He has his main symptoms are storage symptoms. Again, he has no other comorbidities. How are you going to counsel him?
So in terms of the management options, for his storage LUTs, I'll counsel him as to whether it's likely that the bladder stone is causing his storage LUTs. So conservative medical therapy is unlikely to resolve this. I'll counsel him about the surgical options, and these would include in terms of dealing with the bladder stone, a cystolithopaxy, or there is also the laser lithotripsy of the stone, or other means of lithotripsy of the stone, and I'll also counsel him about bladder outflow surgery at the same time, which could be either TURP, mono or bipolar, transurethral vaporization of the prostate, or laser enucleation of the prostate.
All right. What's the classification of bladder stones?
Classification can be based upon size, whether they are solitary or multiple,
Okay.
And composition as well.
Exactly. Based on the mechanism of formation, what's the classification?
So there are those which are formed due to bladder outflow obstruction. There are those bladder stones which could also have been renal stones which have passed through and are now located within the bladder.
Okay. So it is classified into primary, secondary, and migratory. And the primary or endemic bladder stone, we usually don't see it because there is no other urinary tract pathology. For some reason, it is there in the stone is formed in the bladder. It is typically seen in children, especially in areas of poor hydration, recurrent diarrhea, and the diet deficient in proteins. So these are called the primary stones. There is no other pathology, there is a bladder stone. But the secondary ones are if there are other urinary tract anomalies, like in our patient when there is a bladder outlet obstruction. It can also happen in persons with neurogenic bladder dysfunction, if there is chronic bacterial infection. In cases of long-term catheters, there is a 4% risk of developing stones when in long-term catheters. So these are called the secondary stones. Migratory stones are those who have passed from the upper tract and then it acts as an nidus for a further bladder stone formation in the bladder.
Yeah.
So it is primary, secondary, or migratory. This is from EAU guidelines. And you said about the approaches that you counsel him for the treatment of his bladder stone of 2 centimeter. What do you mean by cystolithotripsy?
So this could be using other forms of fragmentation other than laser, and this, for example, includes pneumatic lithotripsy or electrohydraulic or lithotripsy or ultrasound lithotripsy.
Okay, coming to the mechanical cystolithotrite, which device do you use in your practice?
Are you talking, sorry, in terms of the
bladder stone mechanical crushing?
In terms of mechanical crushing, so in my practice I use the stone crusher, which consists of inserting this through a kind of specialized resectoscope of up to 26 French. It involves grabbing the stone away from the bladder mucosa, crushing it between the jaw and the tip of the scope, and then performing this repeated times and then evacuating the stone fragments through the sheath of the scope.
Okay, are you saying about the stone punch?
Yes.
Yeah. So it is called Maurmyers stone punch. The parts are, it has got an outer sheath, as you said, it is 25 French outer sheath. It comes with its own visual obturator. How do we differentiate? It is more elliptical compared to the standard one, which is more circular in cross section, and it has got its own working element. That's why it is costly, because it is in a package. And the main thing, so what type of telescope you use for the Maurmyers stone punch?
So for this, I use a 0-degree telescope.
Well done. And as you said, you have to make sure that the bladder is full. We have to crush under visualization. We have to lift up the stone before crushing to make sure that the bladder mucosa is not involved in the crushing.
Yeah.
And there is also one which is not much popular. If it is a soft stone, we can use something called as a stone crushing forceps. So it is just the forceps only. It has just got a single action jaw, and it fits in the standard 25 French cystoscope sheath.
Yeah.
The only difference is in Maurmyers stone punch we have to use the 0-degree scope telescope, and for the stone crushing forceps you have to use the 30-degree.
Yeah.
But it's not popular because it's a bit softer and it can be used only for small stones. There is one, just for the discussion purpose only. Previously there was one called as a Hendrickson's lithotrite. So what we used to do was to pass it blindly and then feel the stone, and then we had to use a 70-degree scope, just for the discussion purpose only. But we had to know about the Maurmyers stone punch and also about the stone crushing forceps if asked.
Yeah.
So apart from the mechanical lithotrites, what are the other options that you are aware of?
So I'm aware of those which induce lithotripsy using energy. So there's electrohydraulic and the pneumatic lithotripsy, and also the ultrasonic lithotripsy, and laser could also be used with bladder stones.
Okay. What about shockwave lithotripsy? Can we use shockwaves?
They can. This could be considered as an option as well, but it's not very commonly used. Probably due to the bladder stone size often being larger, and therefore the chance of needing repeats sessions is far greater. And the stone there may also be persistent stone fragments in the bladder, and therefore they may not pass out as easily.
Exactly. The EAU guidelines discuss about the shockwave lithotripsy, and there are papers saying that there are success rate around 80%, but it's not popular because we can get better stone clearance and easy stone clearance by using the stone crushing forceps or even using the laser.
Yeah.
And there are options like percutaneous cystolithotripsy, where we can use the suprapubic tract and a sheath and then powder the stone, or we can use the open cystolithotomy if we cannot remove the stones and if there are none of these instruments are available.
Yeah.
And there are situations there are literature based on the laparoscopic cystolithotomy as well.
Yeah.
So that brings us to the end of the technology based on the stones. I hope it was not too exhaustive.
No, not at all.
Thank you. I haven't discussed laser because I think we have already discussed it in the BPH scenario.
Yeah.
We will discuss it again during our 10-minute discussions.
Yes.
Okay, so we will stop here now.
That's very well done. In exam, how the scenarios could be like maybe a ureteric stone or bladder stone or a renal stone. So if it is a bladder stone, as usual, Maurmyers, stone punch, and we can even say laser for the bladder stone, pneumatic lithotripter, and secondary reasons means how to treat the prostate. One of the very commonest scenario now because of hole up is whether we can treat the stone and do the hole up in the same time. And similarly, we can do treatment of stone and TURP, green light laser, or any other energy source at the same time.
Yeah.
When it goes to the ureteric stone, again, the treatment discussions should be like SEMIRIGID ureteroscopy, flexible ureteroscopy, and also ESWL. There is increased stress of ESWL for upper ureteric stones and also renal stones in the new NICE guidelines. So that needs to be kept in mind whenever you are discussing, because the amount of stress for ESWL is very, very, very high compared to the previous editions of the guidelines. When it comes to the kidney stone, it could be an infection stone, so they can take you in the angle of infection stones, pathophysiology, antibiotic prophylaxis, etc. But they won't ask much on mini PCNL, but PCNL is one of the very commonest question asked. Very good. Well done. Do you have any questions to ask?
No, I don't think I have any specific questions. I suppose it's worth knowing all the other PCNL positions because that's the one I've seen used most commonly. Could they ask you about the pros and cons of each position as well for PCNL, such as prone versus supine and so on?
Yeah, I will say that will be more of a higher end question, especially if you are able to bring the Gladico modified Valdavia position, and also if you can bring the simultaneous retrograde ureteroscopy plus PCNL. Those are all practiced in very selective centers for selective patients, especially the Italian surgeons are quite good and a lot of publications in that. But if you can bring those discussions into the table, unfortunately, if the examiner is also a stone surgeon, that will really make into a high good discussion and with very good marks.
Yeah.
Very good. If there is no further questions, we can conclude the session today. Thank you for joining us. Wishing you both a good rest of the day. Bye.
Thank you so much. Bye-bye.
Thank you. Bye-bye.